Um, we have 3 different management of patients. Regulation, UK regulation that we have to adhere to for anybody who is working in the UK. Of course, there's differences in sense of what's available in Iraq and other countries. So I will talk just about the UK standardization and regulation. Obviously, but it's for prevention of death. And then we have the other one, which is called immediate life support, ILS, which is basically for healthcare professionals, includes dentists, and also especially the people who provide sedation, intravenous sedation. Equipment, they can do other things. So we're not going to go a lot into the advanced life support. Basically, I'm going through the basic life support, and I will look at the immediate life support. Our regulations in the UK is governed by the General Dental Council. They are the people who give us license to practice dentistry. And their regulation says that we have to do 10 hours of continuous professional development, which is CPD, in 5-year cycles. And they recommend that's 2 hours every year. Now, this is for General Dental Council. If you don't do that, the license is cancelled. But at the same time, we have something called Care Quality Commission who come and inspect our practices. And these people want us to do 5 hours a year of CPD in basic life support or immediate life support every year. And again, if we don't adhere to it, then again, they have the power to close the practice. The other regulator is called HSE, which is Health and Safety Executive. Again, they request at least 5 hours a year of medical emergency training. And they all follow the Restoration Council UK regulations. So everything that I'm going to talk about now is available on the Restoration Council UK website, plus some more from our own training. So we have to do at least 5 hours a year of medical emergency training, and that's face-to-face. And plus we do some scenarios every 2 months that we have to do a meeting and say, okay, this is the emergency going to happen. Who's going to do what? What are you going to do? What are you going to do? What's the reception going to do? And we play a role. The main thing that we have for saving life is what's called chain of survival. So this is the most important part. Basically, it is related to early recognition of a problem, which is, this mainly talk about the cardiac arrests. So early recognition, early CPR, which is cardiopulmonary resuscitation. And then we need to get as fast as possible the defibrillator. And then when that starts, then we have to move on to the post-resuscitation care to monitor the patient and to restore the quality of life. Now, for the defibrillators, we have what's called automatic external defibrillator, which is not the one that you see in hospitals. These are like self-explanatory, that they are automated. You just put the pads and tell you all the instructions, which I will talk about again in a minute. We'll go through basics, which, as I said, is basic life support. This is in community settings. So this, everybody get trained on it, even sales staff, even people who work in any other, not healthcare, like even in supermarkets. So if they see somebody who's not responding, he's not sleeping and he's not breathing, then the algorithm is to call 999, which is the ambulance. Now the ambulance will prioritize that person. They will send the ambulance right away. And the ambulance will also say where is the nearest external defibrillator, automated external defibrillator, because they are scattered all around in the countries, in the UK, even in villages, in supermarkets. And then they request that you start 30 chest compressions, which is the CPR. After 30, you do 2 rescue breaths. Now, the rescue breaths, obviously, because of COVID, there is some argument that you can continue without it. So for us in the UK, it's not mandatory to do the rescue breaths, but continue just with the chest compressions. And if you have a pocket mask or you have a way of giving the rescue breath, then you continue CPR 30 to 2 until either the AEDs arrive or the ambulance arrive. Now, for the chest compressions, there's difference between doing it for adults, child, or infant. So for adults, it's 2 hands and you press down about 2 inches. For child, 1 hand. And for infant, you do 2 fingers and you press about 1.5 inches. Now, the recommendation is to perform the rate 30 chest compression at a rate of 100 per minute. Now, they recommend that you can do it on the tune of Staying Alive song, because the beat of it is 100 a minute. So that's one of the things. Now, these are the signs that you can find everywhere in the UK to direct you to where is the nearest defibrillator. So tell you is this way or that way, and also tell you exactly what it is. So you call 999, start CPR, switch on defibrillator, and follow the instructions. This is one of the practices, as I said, I work in. And if you look on the right-hand side, there's a yellow box. That is not the one that we use inside the practices. This is for general public. The yellow box looks like that, which is a safe with a defibrillator inside it. The green light in the middle says that it is active and is charging. And when anybody calls the ambulance will direct them to where this and give them the PIN code to open it and use that defibrillator. Now we're going to move to the one that's more important to us, which is immediate life support. The immediate life support, because we are medically trained as a medical staff, although we are dentists, but we have a medical background. So we have opportunity to provide more than just chest compressions and defibrillator. So this is different because we are able to use the report is ABCDE approach. Now the AB was talking again nerve issues. The exposure, there is anything that's causing, is the exposure anything that's causing the problem, like hypothermia or like allergy or anything like that to the skin. So we'll go through them because, as I said, they will come again and again in every other medical emergency. So I'll just go through it afterwards on A, B, C, D, E. But they are continuous monitoring. You have to go through A, B, C, and then if you are managing something in the C, you go back to the A, B, C, and then you move to D and E. So this is basically how they do that. And there are many posters to say, what are they? What's the goal? What's the intervention? Again, they are scattered all around everywhere. And again, there's a different type of poster to need them. You have to double if you come one day to the to the clinic or the practice and you see your secretary or cleaner or whoever, they are collapsed, you have to, first of all, before you approach them, to make sure that it is safe for you. So if there is water, is there an electricity attached to the water or anything like that. So personal safety is number one before you approach the person. And then you need to check the patient responsiveness. Then what is your first impression? What might be the issue? And then you need to check for the vital signs, which will give you a lot of the story. So airway. Airway is, as I said, if there's any obstruction, reasons for the obstruction. CNS depression, which is central nervous system. So if when we do sedation, the tongue can move into the back of the mouth and cause an obstruction. As dentists, we have lots of things that goes and cause obstruction and choking, like the endophile, if used without rubber dam, like crown, bridge, even dentures. Other types of obstruction that can be blood, foreign bodies, which, as I said, like crowns, bridges, dentures, even trauma, like a fracture of the jaw and cause obstruction. Infections, sometimes if the glands swollen, inflammation, laryngospasm or bronchospasm, which is like in cases of asthma or allergy. This is where you have to assess the A. It can be through speaking. That means is it sign of talking. Or breath is not really going in. It's just like very. The treatment of airway obstruction, the main thing airway. First of all, you check if there is anything in the mouth. So you look in the mouth if there is any obstruction as the tongue or anything else. But the simplest way of opening the airway is head tilt, chin lift, and or jaw thrust. And then we can use adjuncts, which we can show you in a minute, and advanced technique. Well, the advanced technique is mainly for hospitals. And we can help by giving oxygen. So the head tilt chin lift, basically, if the patient is lying on their back, you tilt the head back and you pull the chin up. The open obstruction, if in case it's the tongue that moved back, and give you an appointment to have a look inside. Breathing, so that was the A. Now we are moving to the B, which is breathing. Now, recognition of breathing issues, problems, you look. So you look at respiratory distress, you look at the color, which is cyanosis, you look at the respiratory rate, how many they are breathing per minute, chest deformity, are they using accessory muscles? So that means, are they trying to grab on something and breathe rather than just breathing simply? You can also look at the consciousness level, because obviously if they are not breathing, then sometimes they are losing consciousness. Listening, you listen to the breath. If there is any noisy breathing or any breathing sound, at least that means they are breathing, but there is an obstruction in the airway, which is the A. But if there is no breath, that means they may not be tracheal position as they breathe. Once you do the chin lift, head tilt, chin lift, then you can look, listen, and feel. So you put your ears close to the mouth to see if there's any breath coming out, and to see count how many of breathing problem airways. So we go back. it gives you the SpO2, which is a saturation of the pulse. The small ones are not highly accurate, but they give you a good indication. When we do sedation, we don't use this one. We use the hospital trolley one, which is mounted within the blood pressure machine. Then you need to treat the underlying cause if there's a problem with breathing. And if inadequate, then we can do ventilation with bag mask, which is part of our emergency drug kit, which again, we'll talk about it in a minute. Now we move to C. So if A is clear, B is clear, and they are breathing or not breathing, but if they are breathing and they are still collapsed, you look at the C, which is circulation. Now, a lot of causes that can cause circulation problems, there are primary ones and there are secondary ones. There is like septic shock, hypothermia, blood loss. Primary, that means it affects the circulation itself, like the heart or the arteries. Secondary, that means is not affecting it directly. It's circulation. So normal blood loss, not directly related to the directly. For hypothermia, getting cold, hypoxygen level, problems that can affect tamponade, thrombosis, tension, pneumothorax, and toxins. It's very hard to diagnose. Thrombosis or blockage, tension, pneumothorax, that means the chest is not breathing and there is a tension, possibly toxins, circulatory problems. Obviously, heart attack and angina is due to heart issues. So the recognition of circulation problems comes under look at the patient and see if there is any pulse, tachycardia, are they cyanosis. You can also do something which is very, very, very simple to do, very easy to do, which is capillary refill time. So capillary refill time, if you press your thumb on the forehead and you count 1, 2, 3, 4, 5 to 5, you release your thumb, then the color should go back to normal within 2. So 1, 2. Some people use the nail bed, some people use the other places, but the easiest thing is the forehead, because if they have nails, false nails or nail polish or whatever, so it's not going to show, while if in the forehead is the easiest thing, or sometimes on the sternum and the chest, but the forehead is the easiest way. So 5, 2, so 5, press for 5 seconds, release. They should refill within 2 seconds. If they don't, that means there's a circulation problem. Obviously, also you can measure the blood pressure if you have blood pressure monitor handy, like the automated one. Then you can also check, which is again, that relates to hospital rather than in dental practice or general public, which is organ perfusion when they are under the medical health and medical attention. Also, that can be checked like bleeding and fluid losses. That's another thing that can be checked. The treatment of circulation, we go back to A, we treat the A, which is airway. We go back to the B, which is treating the breathing. You give oxygen. And then you can, if you have IV access or intraoral access, then you can take blood, but again, that's mainly for hospital. You need to treat the cause. So if it's angina, if it's myocardial infarction or any other issues, then that needs to be treated to get the circulation back. So, and also there is obviously the acute coronary syndrome, which are the angina or myocardial infarction. There is unstable or stable angina in the myocardial. The treatment for that is, in case of angina, so it's GTN spray or nitrogen glycerin GTN spray or tablets under the tongue. If that does not resolve it, then you move on to aspirin, 300 milligram. They crush it or chew it, and you give oxygen guided by pulse oximetry to know how much to give. But not generally, in the general practice, we give 15 liter per minute. And consider that's another thing that's for the hospital to do, which is in case that there is any blockages for the myocardial infarction or aortic thrombosis, so they might give thrombolysis, but that's for the hospital to do. So we did A, B, C. Now we move to D, which is disability. So disability is basically the consciousness level. In the UK, we use two different things, sometimes AFPU or Glasgow Coma Scale. Now, the Glasgow Coma Scale, as you see on the right-hand side, it is, you give score to everything in there. Are they answering or not? And then you get a number that tell you, are they alert or not? The AFPU one is the easier one to use in general practice. So AFPU stands for alert, that's the A. So that means me, I am alert now, I'm talking to you. And hopefully you're listening to me, so you are alert. V, that means the person is not talking, but they are responding to verbal command. So when you say, wake up, do you listen to me? Are you here? That means they are responding to verbal command. If they are not responding to verbal command, that means now they are moving to P, which is pain. So you need to cause pain for them to maybe be alert or respond to you. So pinching the air loop or putting your hand on the sternum and squeeze. So you cause a little pain, not a lot, to see if they are responding. If they are not responding, then it's you. That means they are unresponsive. Scale. The Glasgow Coma Scale, as I said, is a bit different in the sense of it has many different aspects. And apart from that, we also look at the pupils. Are they responsive or not with the light if you have availability. The treatment for disability, you go back to ABC, and then if ABC are all clear and there is no problem, the capillary refill is fine, they are breathing, and they have good oxygen, but they are not responsive. That means we have to look at what the disability is. And sometimes it can be related to blood glucose, because when blood glucose level goes low, so some patients, they lose consciousness, but they are still breathing and they are, but they are unresponsive. So this is where we use, we can measure the blood glucose, and we can give some sugar or glucose. And consider lateral position, to put the patient in lateral position so that we can have a look at the survival. And check drug chart in case they are taking drugs, especially with dentistry. We have to check medical history for every patient when they come to us, and that's very helpful because then we can tell which medication they used or which medication they had, which is very, very, very helpful. So we have to check the medical, for us, the patient have to fill medical history form before they arrive for every new exam or every 6 months if they are still having treatments. And the final thing, which is A, B, C, D, now we move to the E, which is exposure. As I said, exposure is related to, we can, in certain cases, remove clothes to check if there's any injuries, any bleeding, any rashes. The principle of removing, but we need to be careful when you remove the clothes or anything that's covering them. So we need to avoid heat loss. So we need to cover them with a blanket or heat loss resistant things. But we also have to maintain dignity. So when we say remove clothes, that doesn't mean that leave them naked. You have to maintain dignity and cover them. So that was all the ABCDE approach. Now, whenever we see a patient deteriorating, we repeat the whole ABCDE because things can still change during the treatment or deteriorate more. Now we're going to move to what we do in our practice. So this is our actual practice. Next to reception, see grab bag, which I will go through and what's inside it. On the right, that is the automated external defibrillator we have, and on the left, that orange is like so it's not a bed, it's like a mattress that we can carry the patient, especially because we deal with sedation. So we have some if they lose consciousness and we need to move them to the ambulance outside, so we can lay them on that and we can remove them. The medical emergency grab bag, which is this one, it has all the things that we need for emergency. Well, I say all, almost all, because there are a couple of items you cannot keep them in here, which you open the grab bag, then the most happen on pouch, expecting that may be if they are, and I'll show you quickly what we use or what are these. So this is called eye gel. This is inserted inside the mouth and goes into the trachea right away, and that is to help with the ventilation, that when we can use the grab bag, the face mask with the bag for ventilation with oxygen. This is called oropharyngeal tubes, which again, we just insert it inside the mouth. And again, we can use that to help with ventilation. And this is oropharyngeal tubes, which again, we insert this one through nasopharyngeal, sorry, the last one, through the nose and again to the pharynx. And then we can use that to help with ventilation. On the side of the bag, there is, this is where the oxygen cylinder lives. So you open that and you get the oxygen cylinder with the mask. We have the pulse oximetry and we have the thermometer to check. In addition to that, we also have the glucometer, which you'll see it later within the glycemia pouch. Now, all these things for us, because as I said, we get inspected every year. So we have to check that everything within date, everything is sealed, everything is filled. So the oxygen cylinder, it has to be tested every month. And all these things have to be tested every month, whether we have an emergency or not. Luckily, we don't have much emergencies, although we do sedation in our practice. I personally dealt with about, in the past 15, 16 years, only about 3 emergencies. And I will talk about them later on. But in the UK, it's a big thing if you don't have such equipment and you get a medical emergency, because there was a case where a patient died and the dentist got erased from the general dentist. That means they took his license. He's not allowed to provide dentistry. And it's not because that he did anything wrong as such, but he did not have the proper equipment. And it is the dentist's responsibility to check for the equipment. So it's not the practice, it's not the nurse, it's the dentist. So I have to make sure that these are there and they are in functional order, because if the patient collapse, it's my own responsibility. And I'm not the practice owner. All the dentists who works with me, they also have to check it out. So now we move on to the medical emergencies in dental practice. Evidence of medical emergencies, dental practice, the incidents are not that high, but the ones that are high are vasovagal attack, syncope, which is just basically plain fainting. That, according to studies, is 63%. Angina, 12%. Hypoglycemia, 10%. Epileptic seizure, 10%. Choking, 5%. Asthma, 5%. And anaphylaxis, 5%. I personally dealt, as I said, with the medical emergency with the one I had. Now, vasovagal attack or syncope, for us, we don't consider it as a major emergency because it's very easy to reverse. So I don't, the three that I dealt with, apart from the vasovagal attacks, are the epileptic seizure twice and the what's called hypoglycemia. So, and it was severe hypoglycemia, which again, we'll go to the management in a minute. So, as I said before, the vasovagal syncope or vasovagal attack is the most common emergency that happen in dental practice and is very, very easy to deal with, which is basically just lay the patient back and raise their legs. They normally should come around. But the way to know that this is vasovagal attack when the patient collapses is by, again, going to A, B, C, D, because A is the airway. You know that you look at it and the airway is clear. B, breathing. They are breathing, but they have fainted. C, which is circulation. The capillary fill is fine because you can do the 5-2. So once you do the A, B, C, D, E, and there is nothing wrong in there, then you know it's something that is gonna, you know, but obviously they are D, they are exposure, disability, because they're not responsive when they do the vasovagal. So we'll go one by one. What's the signs, what's the symptoms, and how we manage it in accordance to UK regulation within the RCS UK. So the biggest one, because it's the most dangerous one, and it happens because sometimes of dentistry. That patient that I told you that got struck off, it was because chlorhexidine mouthwash. He gave it to patient. And we used to give chlorhexidine mouthwash all the time, but unlucky for that dentist, that patient was allergic to chlorhexidine that no one knew about. So that wasn't the problem because obviously no one knew about it. But when the patient started having the anaphylaxis signs and symptoms, there was no management in place. So the patient died. If there was a management in place, the medical drugs and everything, and the dentist followed all that, and the patient died, in the UK law and regulation, the dentist is in the clear because he did the proper management. But because that dentist couldn't do the proper management because of lack of equipment, which is the oxygen and the other things I'm going to talk about, then he was held responsible for that. So the anaphylaxis, signs and symptoms can vary. But mainly it's urticaria, which is itchiness, or angioedema, urticaria, itchiness, and also some rash that happens. And angioedema, which is the tongue or the larynx swell, and there's difficulty in breathing. Flushing and pallor, so they go a bit very white or, you know, very light color. Respiratory distress, they cannot breathe. Stridor, wheezing, or hoarseness, that means difficulty in breathing with noises. Then hypotension, which if you have blood pressure, you'll know, and tachycardia. By pulse oximetry, you can tell the pulse rate, or you can even measure the radial artery or the brachial artery, and then you can count how is the pulse. The thing with anaphylaxis, which is different, is sudden onset, that like the patient, you gave an injection or they rinse their mouth and right away they start to get problems. And then it's rapid progression of symptoms, and that the symptoms are very, very fast in coming. Also, the biggest thing, I mean, in the UK, we are almost all are latex-free gloves and everything. But in the UK, there's a high percentage of people who are allergic to latex. So the anaphylaxis, again, so that means the minute they touch latex, or even, you have latex gloves and you touch the patient, they can get that very quickly. Can be life-threatening, and there is the skin or mucosal changes. The treatment management, exactly as I said before. So you assess the A, B, C, D, E. So you assess the airway, that means they are wheezing. You have, but there's no obstruction unless that there is angioedema. So you use the nasopharynx or oropharynx tubes that I showed you. B, they are trying to breathe, but if you get the access, maybe they will be breathing by themselves if they are still okay. But if they are having difficulty breathing, then you have to help with oxygen, with the mask, with bag. And then you look to circulation, you look for disability and exposure. For us, we call 999 right away. We give oxygen 15 liters a minute. You lay flat the patient and try to elevate legs. If the breathing is not impaired, if it's impaired, then you go to the face with mask right away, face mask with bag. And then you give adrenaline 500 microgram intramuscular for adults, which is 0.5 of 1 to 1,000. In the past, we used to have EpiPen, but they stopped the EpiPen because of, which the EpiPen is automatic injector. So it's like a pen, and then the minute you inject it into the thigh, it will deliver the drugs. But they found that, number one, the dose is low because it's only 300, which is almost a child dose, so it's not 500 really. And they found some of them are failing to inject, so you think that you gave the injection, is not. So now for us, adrenaline, we have to mix it and give it by injection. And then you can repeat the adrenaline at 5 minutes intervals if no improvement. Obviously, there are different doses for pediatric. So if it's less than 6 years, you give 150 microgram. If it's 6 to 12, which is 300, and if it's more than 12, is 500 microgram. So this is the pouch for anaphylaxis. It has the algorithm, which I just said. We always keep the algorithm, which is the map or the cheat sheet or whatever you want to call it, to remind, because sometimes you panic instead of, when you are doing things. So at least this reminds you the steps, step by step, what are you doing and what have you forgotten. And then we have the solution for injection, adrenaline, which is epinephrine 1 to 1,000. And as I said, we have to write, because these have to be checked every month to make sure that they are in date, the whole emergency drug kit. So we write on the outside the expiration date, although it's there on the inside, but this makes whoever checking it is easy, life is easier, and the injections in there. Now we give this injection intramuscular. That means to the outer thigh on the right, on either side, or on the arm, but the thighs are better because there is a bit more muscle in there, so you cannot go wrong there. So that's the anaphylaxis. Now we move to asthma. So asthma was the signs and symptoms, breathlessness, and expiratory wheeze. So they don't wheeze when they inhale or when they take a breath. That can be because of choking or something's blocking the airway. But with asthma is wheezing on expiratory wheeze. So when they exhale, when they blow out the air. For adults, when it's severe, it reaches a stage where it's inability to complete a sentence in one breath. When the respiratory rate is more than 25 per minute, so how much the chest go up and down and how many breaths they take. If it's over 25, that means they are really struggling. And the heart rate is over 110 pulse per minute. So these are signs that it is severe. For child, the inability to complete sentences in one breath or too breathless to talk or feed. It depends on the age, obviously. Are they talking or not? The respiratory rate for children can be up to over 40 if they are 2 to 5 years because they breathe more, or over 30 if it's more than 5 years old. Heart rate, anything more than 140 pulse per minute if it's 2 to 5 years old, or over 125 for anybody who's over 5 years old. Now, the life-threatening that becomes really serious is when they become blue cyanosis, poor respiratory effort, they give up because they're tired. There's a fall in heart rate. So although at the beginning the heart rate went up, but then it goes down. And there's altered level of consciousness or confusion. So they are not answering to you, or they are not looking at you. So you can see this is again A, B, C, D, E, because the D is the disability. So altered level of consciousness, fall in heart rate, that's C, that's circulation. Poor respiratory effort, that is B, breathing. So they all goes into the same direction. The treatment or management of asthma, again, we reassess and we treat A, B, C, D, E as we can. So we check for airway, we check for breathing, we check for circulation, we check for disability. We sit upright or whatever comfortable for the patient, but mostly it's upright because sometimes when they lay back, it makes their breathing even more difficult. You give 2 puffs of 100 microgram of a puff of salbutamol, and repeat doses may be necessary. So salbutamol really can give as much as you can, although in some cases it says like, you can repeat it every 10 minutes, but no, you can give it every 5 minutes. It doesn't do any harm in case that they are in that bad situation. If a patient cannot use inhaler, then you have to use a spacer. Our inhaler is already attached to a spacer, which I'll show you in a minute, because when they are in that stage, they may not be able to use the inhaler. Inhaler, that means you have to spray it while they are inhaling, which is sometimes difficult if they are not inhaling comfortably. So that's where they're going to use a spacer. For us, we call 999 if it's unsatisfactory or no response, or if it's life-threatening. So if you use the puffs and they are not getting any better, then you have to call 999. While awaiting ambulance, you give oxygen 15 liters per minute and repeat salbutamol every 10 minutes. Then reassure patients that everything will be okay and keep them calm. This is how we have that asthma pouch. So our inhaler is attached to the spacer. So the inhaler is the blue part, which they can just put in their mouth and inhale, but the spacer basically, you puff it into the space and they keep on breathing. So whatever is in the spacer will go in there through their trachea into the chest. And again, we have the cheat sheet, the crib sheet, or the algorithm, again, whatever you want to call it, and the salbutamol inhaler. And we check that's always in date. The other thing that we can manage or we can face in dental practices is cardiac emergencies. We call it cardiac emergencies because sometimes we cannot differentiate between angina and myocardial to start with. Now, signs and symptoms, again, vary. Commonly tightness or heaviness or pain in the chest. They used to call it the like impending doom, the sense of pending doom. Some patients, they tell you, oh, I feel that I'm going to die. Pain that radiate to the neck, the jaw, the shoulders, left arm and back. And that's especially important because sometimes some cases has been seen in the UK where they think it's a wisdom tooth infection or wisdom tooth problem, but in reality it was angina because it was a jaw ache. Again, they get paler and they start sweating, nausea, sometimes vomiting, and breathlessness. The treatment or management of cardiac emergency, we go back to A, B, C, D, E. So we again assess the airway, the breathing, the circulation, which was compromised, and manage it. Disability and exposure, you call 999. Obviously in the UK, when you call 999 and you say there's a patient who have a cardiac issues or the patient is unresponsive, they go up in priority. If somebody else call the ambulance and tell them, oh, I'm bleeding from my hand, they will prioritize the one with a cardiac issue or the unresponsiveness. But again, there's a catch in the UK. If you tell a patient that when we call the 999, which happened in our practice a couple of times with the oral surgeon, when we tell them that we are a dental practice, they consider us as a what's called safe place. That means they know that we have all the equipment. So we don't go high up in the priority unless it's a cardiac emergency, because they know we can manage or maintain the patient for everything else. So we call 999, we put the patient in comfortable position, again, sometimes sitting up rather than laying back. We give GTN spray, glycerin trinitrate spray, 2 puffs under the tongue, sublingual. If that does not resolve it, then we can move on to give aspirin 300 milligram orally, and they crush it or chew it. And we get the AED in the practice nearby, that in case that there is an issue. If the patient have a history from the medical histories of angina, so we can give GTN and rest. If symptoms are mild and resolve rapidly, then we don't need to call 999. But if it doesn't and it progresses to MI, which is myocardial infarction, then yeah, that's why we have to call, because then he has to be taken to hospital. This is the chest pouch. Again, crib sheet, cheat sheet. We have the GTN spray. Again, the expiry date written on it and checked monthly, and the aspirin 300. Again, the expiry date written on it and checked monthly. Then we move on to the other ones that I faced, the epileptic seizures. Signs and symptoms, again, vary. Commonly, sudden collapse and loss of consciousness, rigidity and cyanosis, jerking movement of limbs, noisy breathing, tongue the patient may bite their tongue. This is especially very, very, very important for us as dentists. If you're working inside the patient's mouth and they develop epileptic seizure, try to remove everything from their mouth. Don't put your hands in there or move their tongue. But if you have rubber dam, if you're doing root canal treatment, you have the clamp for the band and for filling, whatever inside the mouth, you need to remove it. So that's why you need to notice the signs pretty quickly. Frothing of the mouth, sometimes incontinency may happen. That means they defecate or they urinate because of the muscle jerking. The treatment, again, or management, we go again back to A, B, C, D, E. We make sure that the environment is safe. We don't do anything to the patient, anything around them. So the instrument or anything like that, you just try to remove it because we want to prevent injury. But do not put anything into patient's mouth. Do not try to restrain the patient because it should pass. And restraining them, you might be in danger and the patient might be in danger. You need to note the time of it, because if it starts to be prolonged, more than 5 minutes, or petit mal seizure, which is transient, a grand mal, a more serious, continuous. And then we'll go in a minute about what to do in that situation. Once the jerking movement ceases, recovery position, which is on the side, and check for the airway, because if there is a vomit or anything like that, you can use your suction, the dental chair, or we also have a manual suction as a backup to remove any vomit or anything like that in the mouth. If the seizure prolonged more than 5 minutes or there's repeated seizures, then we give midazolam oral mucosal solution, which is bacozolam. So this type of benzodiazepine, which is the same thing that we use midazolam for sedation, but this one is like an injection, but with no needle, and you just give it to the side, the buccal side of the teeth, and that will be approved buccal mucosa, and it should help the pit. A single dose of 10 milligram for adults. This is our epilepsy pouch, again, cheat sheet, and this is the bacolam, which is the injections, 5 milligram. So we give both of them, 2 at a time, if needed. Now, this is the only thing which is different about the epileptic seizures, because sometimes we need to call the ambulance, sometimes we don't need to call the ambulance. The way we differentiate between those times is depending on the response. If the seizure is continuing 5 minutes after the emergency medication has been administered, which is the bacolam, then we need to call 999, because that's, again, grand mal seizure that is not resolving. If the patient has a history of frequent episode of serial seizure, the patient do follow that. That means to call a fit. We kept him in a safe position with the thing and so on, and he recovered, but we couldn't let him go because it was his first time. And then we had to call the ambulance. The ambulance did all the checks to him when they took him to the hospital. Because that's how it works here in the UK, because that patient will not be allowed to drive for 6 months unless to monitor if there's any additional seizures in there. So we have different rules and regulations. Or if there are difficulty in monitoring the patient ABC. So if you cannot monitor the airway, breathing, or circulation for one reason or another, again, we have to call 999. Now, there is pediatric doses of the bacolam, which is, as stated, if it's 1 to 5 years, 5 milligram, 5 to 10 years, 7.5, over 10 years is like adult 10 milligram. And there's the pediatric doses. So we have it in 2.5, and that means we give 2 of them if it's 1 to 5, or 3 of them if it's 5 to 10. If it's over 10, then we can give the adult one. Then other common thing that can happen is hypoglycemia, especially if you have diabetic patient who did not eat their breakfast, but they took their medication, or even just anxious patient. And again, because I deal with patients with sedation, so we get a lot of anxious patients. The safest thing sometimes to do is, I mean, I know we are dentists, but giving sugar is not going to do any harm. If you think the patient's anxious or they are a bit on the edge, just give them any sugary drink before you start, as simple as that, or glucose tablets or dextrose tablets. But anyway, if hypoglycemia start to happen, then the signs and symptoms is shaking, trembling, slurred speech, vagueness. So start talking about nonsense. Start talking about things that are not there. Sweating and pallor, blurred vision, tiredness and lethargy. That means they just so tired they cannot do anything. Confusion, aggression, and aggression, moody, and sometimes even loss of consciousness. Again, that is going back to ABCDE, because that's disability, and you can tell them that after, which is, are they alert? Are they responding to verbal? Are they responding to pain? Or are they responsive? The treatment, as I said, ABCDE, and then offer 15 to 20 grams of fast-acting glucose, like glucose tablets or orange juice or glucose gel, can of Coke, not the diet one, Hypostop, which is a glucose gel. So this is very easy to manage, and you have to have these in the practice. If there's impaired consciousness of the patient is unable to swallow, then we have glucagon 1 milligram intramuscular auto injector. So that's again the injection, which is a pre-filled, and the minute that you hit it on the side of the knee, of the thigh, obviously with the clothes on, it will penetrate the clothes, go and give the glucagon. The main thing about the glucagon is the way it works is to metabolize or mobilize, sorry, any sugar that's left within the liver. So that is very, very, very fast acting, but also is very short term, because once that sugar is metabolized, then, and the patient is awake, you have to right away give oral glucose. If you don't give, then the patient will collapse again. So the minute the patient is conscious, then you have to give, again, fast-acting glucose or glucose tablet or orange juice or can of Coke or Pepsi, the full sugar one, or anything just to pump up the sugar in the patient's mouth and the patient blood. Then if the patient went unconscious again, that's why we call 999. We'll measure blood sugar to confirm diagnosis, which we have glucometer, which I'll show you in a minute. Again, there's a difference in the pediatric dose of glucagon. If it's less than 8 years old, or less than 25 kilogram, then we give half milligram. So the thing with the glucagon, they are kept in the fridge. So sorry, I didn't take a photo of it. But again, we have the cheat sheet, we have dextro tablets, we have glucogel, which is hypostop, and we have the glucometer that help us in diagnosis as well. Stroke, again, it can happen because of anxiety and increase in blood pressure sometimes when patients come to the dentist. Signs and symptoms of the stroke. In the UK, again, stroke is a big thing, and it's everywhere. You see posters, because stroke is something reversible if you acted very, very fast. And that's why they use the acronym FAST to diagnose stroke. So face, has the face fallen on one side? That means they cannot smile or speak normally because one of the side is dropped. So that's face. The arm, can they raise both arms or just one of them? And can they keep them raised up? Because with stroke, sometimes you get weakness in either left or right side. Speech, is their speech slurred? Are they finding it difficult to speech? If you have that, of patients who's suffering from that, then it's time to call 999, because the faster you act, the better the prognosis of the stroke. So that's why they used the word fast. So face, arms, speech, time. If there's a weakness in the face, weakness in the arm, speech problem, time to call 999. So it's the same thing for us as in dentistry, and then we have to call the ambulance because they have to give thrombolytics, which obviously we don't have in the practice, but the faster they do it before that part of the brain dies, then the faster the recovery. The treatment, we try to do ABCDE. In this scenario, this patient, he wouldn't have any issue with the A or the B or the C, because airway is clear, he's breathing. C, circulation is fine because it's not related to the heart. D, disability, they have disability. They are not answering you because of the speech, but they are awake. So the AFPU is they are alert. Yes, they might answer you, or they might answer you to verbal, which is the V, but definitely they normally don't go into the pain or unresponsive. So call 999, you give oxygen 15 liters per minute. You don't do anything, you don't give them anything by mouth, because as I said, there's no management for us, it's for the hospital. The most common one in dental practice, syncope, which is vasovagal attack. So patients feel dizzy, faint, lightheaded. They might collapse and lose of consciousness. They sometimes become pallor, sweating, slow pulse, low blood pressure. In some cases, again, there's nausea and vomiting. Treatment, again, ABCDE, assessment, lay flat and elevate legs and loosen any tight clothes. Consider oxygen if you have pulse oximetry and the SpO2 is low. If become unresponsive, then you have to keep on reassessing ABCDE. Once consciousness is regained, then you offer glucose, because although they are not hypoglycemic, but hypoglycemia can lead to syncope or vasovagal attack. So, you can offer glucose anyway. But as I said, it's self-limiting. Adrenal crisis, this is a bit of very specific one because it's mainly happen, or Addisonian crisis that it used to be called. It's mainly happened with patients who have a history of taking steroids, high doses of steroids or even medium doses of steroids. In the UK, obviously we follow the UK rule, but I know like in the USA, they have a different regulation regarding patients who use steroids, that sometimes they double the dose of steroids that they take for the patient to cope on the day. In the UK, we don't do that. We don't play around with steroids or anything like that. We treat the patient as they are. We manage the symptoms as they are in dentistry. So the patient may collapse, became pallor, cold and clammy skin, vomiting and diarrhea. The treatment, you assess A, B, C, D, E, you call 999, lay flat and give oxygen. So it's basically adrenal crisis or a vasovagal attack if they don't regain consciousness, more or less the same thing, because there's nothing we do about it in dentistry. And that's why we don't have even a grab bag for it, just that we give oxygen. The common one, again, that happens in dentistry, or can happen in dentistry, shouldn't happen, but it can happen, it's choking. So with choking, we assess severity. If it's mild, the patient is choking, but they are choking, then you encourage coughing and continue to check for deterioration. If the patient is not coughing effectively, then encourage them. Or if the obstruction does not relieve and it moved to a severe, then that means the airway is obstructed, so inefficient coughing. Then is the patient conscious or unconscious? If it's conscious, then we give 5 back blows on the back toward the top. We lay the patient down instead of forward, so that we encourage that to dislodge whatever has fallen. Then we can do 5 abdominal thrusts. This is what used to be called Heimlich maneuver or Heimlich maneuver. Apparently, we are not allowed to use that name again anymore because his wife refused to use the name on that maneuver. So now it's called 5 abdominal thrusts, which is basically you stand behind the patient, you grab the abdomen and squeeze, and that should dislodge it. If the patient is unconscious, then you start CPR right away and you go again A, B, C, D, E. So this is a summary of what emergency drugs we keep in the dental practice. And this is for us in the UK required by law. We, if we get inspected and there's one of these are not there or it's expiry, then we get shut down and somebody have to take responsibility. And I said that dentist who had that anaphylactic shock patient did not have the proper drugs in the practice. The patient died and he got punished for that. But if that patient had anaphylaxis and the dentist had those drugs, he used them, even if the patient died, which is unfortunate, but he wouldn't get any any responsibility because he managed it as per guidelines. So the drugs are adrenaline, aspirin, glucagon. So as I said, the adrenaline is for anaphylaxis, as I showed you, and aspirin, it's for suspected heart attack. Glucagon, which is for hypoglycemia. Glucose, that's the fast acting for hypoglycemia. And then GTN spray, that's for angina. Midazolam, which is bacolam. And we can use the short acting. Sorry, I don't know who's typing. And then there's the short acting beta agonist for asthma, which is the salbutamol. Sorry, I just have to stop there because I don't know what's happening in there. Leif, Qais, Qasim, can you please stop writing and delete everything? Thank you. The main thing that you have to also understand that we have to assess our patients. I don't know if you're familiar with ASA classification, which is American Society of Anesthetists classification. This basically classify how healthy or how unhealthy a person is. So there's ASA 1, 2, 3, 4, 5, and 6. The 1 is a normal healthy patient who's non-smoker, healthy, does not take any medication, no minimal alcohol use. ASA2, they have a mild systemic disease. So, even if they have, for example, blood pressure, but it is controlled. If they are pregnancy, obesity, but again, there is a limit to my body mass index between, it has to be maybe more than, no, it has to be, sorry, it can be more than 30, but less than 40. And there are other diseases, but as long as they are managed, then it's ASA2. ASA3 is when they have severe systemic disease, so like poorly controlled diabetes mellitus, or COPD, diabetic knee patients, or BMI over 40. So these are ASA3. 4 is the patient who have severe systemic disease and there is severe constant threat to life. 5 is the patient who is almost dying if there is no intervention by hospital. 6, these are brain dead patients and they are in hospital to become organ donors. The reason you have to know that because you have to assess the patient before you start with any dental treatment or sedation treatment. We mainly deal with ASA1, ASA2. We don't, in general practice, deal with ASA3, 4, 5, or 6. But again, sometimes it depends on the type of treatment. So if it's a simple filling, if it's exam, then we can do ASA3 as well. But when it goes to 4 or 5, then you need to be very, very careful because there is a risk to life. The easiest way to remember the ASA classification is by remembering the stairs. So SA1 is diagnosed as a person who can go full flight of stairs and continue with no difficulty. ASA2 is a patient who can do the full flight of stairs, but they have to stop at the end because they are so tired. ASA3, when they cannot even finish a flight of stairs, they go halfway. 4, the ones that cannot even go up. 5, as I said, they are morbid bound within 24 hours if there is no intervention by the hospital. So in summary, there is a huge importance of taking medical history in advance because that will give you a thumbs up before starting with any treatment. The way we deal with emergencies in dental practice, which we do scenarios, as I said, every 2 months, the basic thing that you do is you approach the patient, and as I said, you have to make sure that the environment is safe. We do what's called shake and shout. So we shake them by the shoulders, and we shout, "Are you okay? Can you hear me?" Because maybe that person is asleep, not necessarily your patient, but maybe somebody in the street. So the shake and shout. Then, if that is not responding, then you do the head tilt, chin lift to check for airway. Then you listen, feel for the breathing and count. Then you check for circulation by capillary fill or by pulse oximetry. Of course, the pulse oximetry is very important with the glucometer because it can eliminate a lot of emergencies for you. If the pulse is okay and if the oxygen saturation is okay, but the patient is unresponsive, he may be having epileptic fit or silent fit or vasovagal attack. The glucometer, if the glucose level is okay, then the patient may be or not okay. That means it's hypoglycemic. So in dental practice, once we reach to that stage, first of all, we call for help. So we call for any nurses or any doctors in the other practice. They bring the medical emergency bag, and then we play that scenario, or not we play that scenario, we go through the scenario that we already know, that we assess A, B, C, D, E, if we need to do the AED and we attach it to the chest, and we go through all that management that we discussed individually. There is an importance of early recognition of the signs and symptoms because, as I said, if you recognize that it's not breathing and airway and there is no circulatory problems, then it might be something related to syncope or hypoglycemia, for example. But if you recognize things early, then you can treat it early before it develops into a bigger problem or the patient loses consciousness. Regular training, as I said, we play that scenario, once a month or once every 2 months, but by regular, we have to keep a log by once a month, and because when we get inspected, then they look at that and they tell us what have you done. And thank you. This is all what we were talking about medical emergency management in the dental practice. So I don't know if any of you have any questions.
شكرا لك دكتور نبراس على المحاضرة الحلوة. صراحة المعلومات كلش مفيدة. أنا صح يعني اختصاصي بعيد عن طب الأسنان، بس تعتبر كمعلومات عامة نقدر نستفاد منها بأي مكان. كلش حلو، عاشت إيدك.
هلا مرحبا، هلا مرحبا. يعني
اخوان اذا عندكم سؤال الدكتور ما طول هو موجود يستقبل اسئلتكم ويجاوبكم ان شاء الله. رابط الحضور نزل على الشات، اذا تحبون تسجلون حضور توصلكم شهادة مشاركة بالمحاضرة. المحاضرة ايضا مسجلة، راح نبثها على اليوتيوب، على منصة اليوتيوب ايضا. دكتور تمام، الظاهر ماكو سؤال. نشكر تواجدك المرة الثانية ويانا، وكلش اسعدتنا محاضراتك. ان شاء الله التواصل معك يعني يظل دوم وترفدنا بكل المعلومات اللي حضرتك مبدع بها صراحة.
شكرا، هلا مرحبا.
مع السلامة.
مع السلامة.